Assalamu alaikum warahmatullahi wabarakatuh. To carry on with the special embryology lectures, I'm gonna discuss today the development of the pharyngeal arches. I'm Dr. Dalia Saleh, Professor and Head of Anatomy Department at Mansoura University. And the objectives of my presentations will be about: first, I will discuss the general features of the pharyngeal arches and the aortic arches, and the derivatives of each of the following: the pharyngeal arches, the aortic arches, the pharyngeal clefts, and the pharyngeal pouches. And finally, I will talk a little bit about the anomalies in the development of the pharyngeal arches. First, what are the pharyngeal arches? They are also known as pharyngeal arches. And by pharyngia, we mean gills, like you can see in this big fish here. However, the human embryo does not develop a true gill like the amphibians or fish, because there is no communication between the exterior and the interior. That's why the pharyngeal arches are the accurate naming of these structures. They appear between week 4 and 5 of intrauterine life, and they are the base for the development of the head and neck. Each arch is built around the aortic arches between the dorsal and ventral aorta. That's why we need to talk a little bit about the aortic arches, and I'm gonna discuss them in more details in the development of the arteries. If you look at this diagram, you're gonna see that we have certain sets of arteries that will go extensive remodeling later on. We have a pair of dorsal aorta, and by dorsal I mean that they develop behind or dorsal to the foregut. They unite together and form a single dorsal aorta. And we also have two pairs of ventral aorta that communicate with the developing heart. Both ventral and dorsal aorta are connected by 6 pairs of arches. They are called aortic arches. They are numbered from 1 to 6. However, the 5th aortic arch disappears rapidly or doesn't develop at all. After remodeling, the previous arteries will give us the adult arteries here. You can see in this diagram, you can see the aortic arch, the pulmonary trunk, and the arteries that arise from the aortic arch, like the brachiocephalic, the left common carotid, and left subclavian arches. Back to the pharyngeal arches. In order to figure out or imagine how they are arranged, let's look at this diagram. This is a section in the embryo. Here you can see the developing heart. Dorsal to it lies the neural tube, and ventral to the neural tube lies the developing foregut. Its cranial ends will form the pharynx. So again, you can see from dorsal to ventral, the neural tube, the pharynx or the dorsal part or the cranial part of the foregut, and the developing heart. So the pharyngeal arches are mesodermal thickenings in the wall of the pharynx. They fuse ventrally, ventral to the pharynx. And if we look from a different view, you can see the following. You can see the neural tube here, and along the neural tube lies the neural crest cells. Ventral to the neural tube lies the pharynx, and on each side of the pharynx you can see the pharyngeal arches numbered from 1 to 6, and each arch wrap around the pharynx and they meet ventrally or fuse ventrally. Also in this diagram you can see the neural crest cells that will migrate and invade the developing arches. By the time that the anterior neuropore closes, the first and second pharyngeal arches can be seen. This is the first arch and this is the second pharyngeal arch. Even in the first pharyngeal arch, you can see two prominences, the maxillary prominence, and also the mandibular prominence. This is another view of an embryo in early stage of development. In the middle you can see the stomodeum, or the future mouth opening. Here is the two nasal pits that will form later on the nose, or the nasal openings. We can see the first pharyngeal arch with its two prominences, the maxillary and the mandibular. We also can see the second pharyngeal arch. Also, in this view, we can see the third arch and the fourth arch that are all visible externally. Remember that I said that the fifth arch doesn't develop or soon degenerates, and the sixth arch does not form an external elevation. So if you look at the embryo from this view, you only can see four elevations: the first arch, the second arch, the third, and fourth. If we take a cut section in the previous picture to see the components of each arch, we will find that they are covered from outside with ectoderm and lined from inside by endoderm. The ectoderm deepens in between the arches, forming what's called pharyngeal clefts, while the endoderm forms pouches along the lateral wall of the pharynx. We call them the pharyngeal pouches. The area between the cleft and pouch is called the pharyngeal membrane. In the middle, we have the mesodermal component of the pharyngeal arch. We call it the mesenchyme. And remember that the mesenchyme is undifferentiated mesodermal cells. They may develop into cartilage or bone or even disappear. For the nerve supply of the pharyngeal arch, we have traumatic nerves, and the word trema means a trench, referring to the trenches that lies between the pharyngeal arches. These nerves could be motor, could be sensory, could be both. They supply not only the muscular component of the arch, but will also supply the skin and mucosa as well. So we have two types of nerves. The post-traumatic nerve, it lies cranial in the pharyngeal arch. It is the main nerve supply of the arch. And another one derived from the arch below it, we call it the pre-traumatic nerve. It lies caudal in the pharyngeal arch. Each arch also gives us a muscular component, striated muscles that lies here in or derived from this pharyngeal arch, and if they migrate away from the arch, they will drag the nerve supply with them. Also, we have vascular component, or the artery, which is derived from the aortic arches. The endodermal component of the pharyngeal arches give us the glands of the neck. Let's start with the first pharyngeal arch. The skeletal component of the first pharyngeal arch are derived from the neural crest cells that migrate. Remember that we have two prominences here, the maxillary prominence and the mandibular prominence. They will give us the bones of the face, like the maxilla and the zygomatic bone, and also the temporal bone. Also, it will give rise to the incus and malleus in the middle ear. These are the small bones that lie inside the middle ear. The anterior ligament of malleus, the sphenomandibular ligaments, and of course the mandible. In this case of abnormal development of the first arch, there is deficiency in the migration of the neural crest cells to the first pharyngeal arch. So there is no development of the skeletal components of this arch. That's why this baby is developed with lacking of mandible, and also a problem in the development of the maxilla and zygomatic bone and so on. The muscular derivatives of the first pharyngeal arches are the muscles of mastication, as you know them, the temporalis, the masseter, the medial and lateral tracheoid muscles. Also, the mylohyoid and anterior belly of digastric, tensor tympani and tensor palati muscles. For the first pharyngeal arch nerves and arteries, the post-traumatic nerve is the mandibular division of the trigeminal nerve. It contains both motor and sensory nerve fibers, and also by the maxillary division of the trigeminal nerve, which is a purely sensory nerve. For the pre-traumatic nerve, it is the chorda tympani of the facial nerve. It gives taste sensation to the anterior two-thirds of the tongue. For the artery, we have the maxillary artery. The second pharyngeal arch, the skeletal component, it will give the stabes, styloid process, stylohyoid ligament, small or lesser horn of the hyoid bone, and superior part of the body of the hyoid bone. So you can memorize them by the 5S. For the muscular component, the second pharyngeal arch muscles are those of facial expression. We call them facial expression muscles. And also we have the platysma, posterior belly of digastric, stylohyoid muscle, and stapedius muscle. For the nerves and artery, the post-traumatic nerve is the facial nerve, which is motor to the previous muscles, and pre-traumatic nerve derived from the lingual branch of the glossopharyngeal nerve that will give a taste sensation to the posterior one-third of the tongue. For the artery, we have a small artery called the stapedial artery. For the third pharyngeal arch development, the skeleton of the third arch is formed from the greater horns and the lower part of the body of the hyoid bone. And for the muscles, we have one muscle only, which is the stylopharyngeus muscle. The post-traumatic nerve will be the glossopharyngeal nerve, it's the motor component. And the pre-traumatic nerve will be a branch from the internal laryngeal of the vagus nerve, which will carry the taste sensation to most posterior part of the tongue. And for the arteries, we have the common and internal carotid arteries. Regarding the fourth pharyngeal arch, the skeleton will form the thyroid cartilage. The muscles will be the cricothyroid muscle, and the post-traumatic nerve is the external laryngeal nerve, which is motor to the cricothyroid muscle, and we don't have pre-traumatic nerve for this arch. And for the arteries, in the right side we have part of the subclavian artery, and in the left side we have the distal part of the arch of the aorta. Remember that the fifth arch is rudimentary and disappears, while the sixth pharyngeal arch, now I'm going to talk about it. Its skeleton component will form the rest of the laryngeal cartilages. The muscles will be the rest of the laryngeal muscles, except of course the cricothyroid. And also we have the pharyngeal muscles, palatal muscles except the tensor palati, because it is already developed from the first arch. For the nerves, we have the recurrent laryngeal nerve, both motor and sensory. And for the arteries, on the right side we have the right pulmonary artery, and in the left side we have the left pulmonary artery and ductus arteriosus. Let's go back to the aortic arches and see how they develop. look at this simple diagram. We have two dorsal aortae, and when they communicate with each other, they form a single dorsal aorta. We have the aortic arches, 1, 2, 3, 4, 5 is not present, and this is the sixth aortic arch. And below this level, we have another artery called seventh intersegmental artery. You can notice that before remodeling, there is symmetrical development of the arches. The right and the left side looks the same. So for the first aortic arch, it will give us the maxillary artery. The second arch will give us the stapedial artery. Now let's look at the third aortic arch, the purple one here, and see what happens to it after remodeling. The third aortic arch will give us the common carotid artery from its proximal segment, and its distal segment will give us the internal carotid artery, and the external carotid artery just arise as a sprout from the middle part of this arch. For the development of the fourth aortic arch, the light blue one here, this is before remodeling, and what happens to it after remodeling? It will give us on the right side the proximal part of the right subclavian artery, while in the left side will give us the distal part of the arch of the aorta. Remember that the fifth aortic arch doesn't develop, so let's see how the sixth arch develops after remodeling. It is the dark blue one here, focus on it. So the sixth aortic arch, in the right side, it will give us the right pulmonary artery, while its distal part disappears. On the left side, its proximal part will give us the left pulmonary artery, while its distal part persists as ductus arteriosus that communicates the left pulmonary artery to the arch of the aorta. Now let's have a look at this small artery that arises below the level of the sixth aortic arch. We call it the seventh intersegmental artery. After remodeling, in the right side, it will give us the distal part of the right subclavian artery, while in the left side, it will give us the left subclavian artery. Now let's have a look at the pharyngeal clefts, how they develop. The first pharyngeal cleft will develop into the external auditory meatus and the outer layer of the eardrum. Remember that the outer layer of the eardrum is ectodermal in origin. And the dorsal part here will develop into the ear helix or ear pinna, while the ventral part will become rudimentary and disappear. From the second to the fourth pharyngeal clefts, they will form the side of the neck. The mesenchymal component of the second pharyngeal arch will grow caudally and covers the third, fourth, and sixth pharyngeal clefts and meet or fuse with the epicardial ridge, which is a small ectodermal ridge at the root of the neck. So after they meet together and fuse, they will form a sinus. It's called the cervical sinus that will obliterate gradually and disappears completely. For the pharyngeal pouch's development, remember that they arise from the endoderm that lines the pharyngeal arches. So for the first pharyngeal pouch, distally it widens into a sac-like structure, forming the middle ear cavity and the inner layer of the eardrum. So the eardrum is formed of two layers. Outer one is ectodermal in origin and the inner one is endodermal in origin. While its proximal part remains narrow to form the eustachian tube. Thus, the first pharyngeal membrane forms the eardrum. For the second pharyngeal pouch, it will form the palatine tonsil. The third pouch ventrally will form the thymus, and of course the thymus will migrate downwards to get to its final destination in the upper part of the thorax behind the sternum, while dorsally it will form the inferior parathyroid glands, which will also migrate downward. The fourth pharyngeal pouch will form the superior parathyroid glands. The fifth pharyngeal pouch will form a body called the ultimobranchial body. Its development in the human is controversial. Probably it gives the parafollicular cells or the calcitonin producing cells of the thyroid gland. Now, what are the abnormalities in the development of the pharyngeal arches or pharyngeal apparatus? We could have anomalies regarding the development of the ear pinna, as in this anomaly which is called the preauricular fistula. And it is because of the improper fusion of the ear hillocks. So we end up with a small fistula in front of the auricle. That's why it's called preauricular fistula. The second anomaly, or the second type of anomalies, is because of the improper fusion of the second arch and the epicardial ridge, leading to the persistence of the cervical sinus. So we end up with what's called the pharyngeal cyst, a swelling in front of the sternomastoid at the side of the neck. Sometimes it opens by an opening on the surface. We call it the pharyngeal sinus, or even open to the pharynx. So we call it the pharyngeal fistula, and in this case it will open at the tonsil. Another anomaly regarding the thymus and the parathyroid tissue, because these tissues migrate downward from their original developing site to their final destination in the adult. So we could end up with remnants of their tissue persist along the pathway of their migration, as in the thymus gland here. If you look at this diagram, you can see the green arrow here points at the normal pathway of migration of the thymus gland. And here you can see the remnants of the thymus tissue along the pathway of its migration. Also, because of the migration of the inferior parathyroid downward, we can end up with variable position of the inferior parathyroids, as you can see in this diagram. Okay, this is the normal position of the superior parathyroid at the posterior border of the thyroid gland near its upper pole, and this is the usual position of the inferior parathyroid near the lower pole of the thyroid gland. However, this green area represents the variable position that you can see the inferior parathyroid at. Even it can migrate downward inside the thorax, or even you can see it at the bifurcation of the common carotid artery high up. This is the end of my presentation. Thanks for listening. I hope you enjoyed it. Please do not forget to subscribe, like, and share.